Well, good evening. Hello, everybody. It's my pleasure to welcome you. This is the first wave in 2021. As you know, in 2020, we had around 13 cardio risk waves and two IAVA case box with the ACC and the two international lipid summit. So I hope this year we can do the same achievement as we did last year. So this is the first wave in 2021 of the cardio risk waves, and I have the pleasure to have a great faculty with me, speakers and moderators. We will have about 5 presentations, and I would after 30-second break, I would leave the stage to Professor Atif Al-Bahari, Ahmed Shaheen, and Walid Abdu to start the first session. So 30-second break. Be with us. Stay with us, please.
Hello, everyone. I'd like to welcome you all in the first wave of cardio risk of IAVA, and I have the honor to be a moderator in the first session with Professor Walid Abdu and Dr. Ahmed Shaheen. I will introduce my dear colleague, dear friend, Professor Hani Raghi, consultant cardiologist at National Heart Institute, and he will speak about the risk categories and dyslipidemia goals of LDL cholesterol in diabetics, according to the European Society of Cardiology, European Society of Cardiology Dyslipidemia Guidelines in 2019. Professor Hani, please.
Thank you very much, Professor Atif Bahari, Professor Ashraf Rida, dear colleagues, dear panelists, dear IAVA panelists, and dear attendees. I'm going to summarize the LDL cholesterol targets, including those in diabetes, which was my original slides, in the recent guidelines. In the dyslipidemia guidelines of the ESC/ASC. I'm going to finish this in about 16 slides, and hopefully you should have about 4 or 5 minutes for questions. So anyway, the foundation of the new European guidelines of atherosclerosis is that they recognize that LDL lipoproteins, low-density lipoproteins, and other ApoB-containing lipoproteins cause atherosclerotic cardiovascular disease. These guidelines, therefore, make recommendations to reduce the risk of atherosclerotic cardiovascular disease by lowering LDL and also lowering other ApoB-containing lipoproteins. And these guidelines recognize that the benefit of lipid-lowering therapies is determined by 2 important things. The first is the absolute reduction in LDL and other ApoB-containing lipoproteins, and the corresponding absolute reduction in atherosclerotic cardiovascular risk. So these guidelines therefore recommend titrating lipid-lowering therapy intensity based on 2 factors. The first one is the baseline lipid levels, how high is the lipid levels, and the second one, which is as important, if not more important, is the baseline risk of atherosclerotic cardiovascular disease. So for the first time in those guidelines, there was prioritization of identifying people at high and at very high 10-year risk of experiencing a cardiovascular event, because those 2 groups are the most likely to derive the greatest short-term clinical benefit from intensive or aggressive lipid-lowering therapy. So let me put some definitions so that we can all remember them. We're going to talk about using baseline LDL and using risk to estimate the expected clinical benefit of LDL lipoprotein lowering therapies. So if you look in the upper square here, intensity of lipid lowering treatment. If we talk moderate intensity statin, we're talking about an average of 30% LDL reduction. If we're talking high intensity statin, we're talking about a 50% LDL reduction. If we're talking a high intensity statin plus ezetimibe, we're talking about a 65% LDL reduction. Now look at this and be very careful here. If you look at PCSK9 inhibitors alone, you're talking about 60% LDL reduction. That's actually could be less. You can achieve more than that in a much cheaper fashion if you are in the developed world with a high intensity statin plus ezetimibe. And as we know in the AVA group, several of our colleagues, namely Professor Sameh Emil, keep showing us patients with LDL below 40 on this combination without PCSK9. Now, if you use PCSK9 with moderate intensity statin, you're going to get a 75% reduction in LDL cholesterol. If you use, as you should, PCSK9 with high intensity statin with ezetimibe, you are going to get to the figures which you really want to see, which is very, very low LDL of 85% reduction in LDL cholesterol. So you look at this is the percentage of LDL cholesterol, and you look at the baseline which you had. This is called the absolute reduction of LDL cholesterol. And you look at the relative risk reduction from the baseline risk, and you look at the absolute risk reduction. And that is how you calculate things, and these are the definitions. So the recommendations for cardiovascular disease risk estimation. How can you estimate who is at very high risk and who is at high risk and who is at an intermediate risk? You can estimate by 3 stages. The first stage is clinical evaluation of the patient. By the way, everything which I'm going to say now is a class 1, and level of evidence is expert opinion, is C. So you clinically evaluate, you high and very high risk individuals. How are they identified? They are identified on the basis of documented cardiovascular disease or on the basis of being adult diabetics, or having moderate to severe renal disease, or very high levels of individual risk factors, or having familial hypercholesteremia, or having a high score risk, and I'll discuss the score risk in a minute. It's recommended that such patients are considered as a priority for advice and management of all risk factors. So if you see a patient with diabetes mellitus who's 45 years of age, who doesn't smoke, who exercises, who's not hypertensive, this is a patient with high or very high risk. So you should be able to identify them based on this data. It's not based on looking at the patient. There's also the SCORE, which is a 10-year risk estimate. A total risk estimation using a risk estimation system as the SCORE, or if you're using the ACC risk estimator, that's also acceptable, is recommended for asymptomatic adults who are above 40 years of age without evidence of cardiovascular disease, diabetes mellitus, chronic kidney disease, or familial hypercholesteremia, or an LDL above 190. If any of those things exist, you don't really need to do the SCORE. If none of those things exist, it's recommended that you calculate the patient risk using a calculator, a risk calculator like the ESC SCORE, which is available online, and everybody can put it on their cell phones. I have it on my mobile phone, and I do it for every patient. The other thing you need to look at, which is in selected individuals who appear to be at low or moderate risk, you need to look at risk modifiers or risk enhancers. And these might be increased ApoB, increased lipoprotein little a, or increased C-reactive protein, or a family history of premature atherosclerotic cardiovascular disease, or the presence of atherosclerotic plaque on imaging, or heavy calcium score. And these may improve risk stratification and inform treatment decisions. So those are things that you should look at in patients who seem to be at lower risk, to be sure that they are indeed at lower risk. So let us go to the cardiovascular risk categories. Who is at very high risk? People with any of the following are considered at very high cardiovascular risk. Those who already have atherosclerotic cardiovascular disease, whether it's a clinical event, and I'll discuss that in a minute, and I'll discuss the definition, or unequivocal imaging findings. So clinical events include previous ACS, MI, or unstable angina, include stable angina, chronic coronary syndromes, include any patient who has had a coronary revascularization, PCI, bypass, or other arterial revascularization procedures, include patients who've had a stroke, include patients who've had the TIA, and include patients, most importantly, with peripheral arterial disease who may be missed. We should know how to examine them. We should know how to do ankle brachial index and other parameters of detecting peripheral arterial disease, and history should be taken. Now, what about imaging? Unequivocally documented atherosclerotic cardiovascular disease on imaging includes imaging findings that are known to be predictive as clinical events. So significant plaque or on coronary angiography or CT scan, which is multivessel coronary disease with two major epicardial arteries having more than 50% stenosis, or significant plaque on carotid ultrasound. We do not consider thickness of the IMT as documented atherosclerotic cardiovascular disease. The definition is clear in front of you. It has to be significant, not just any small amount, which is like a minimal lesion in one artery. That's not considered documented atherosclerotic cardiovascular disease by imaging. Diabetes mellitus with target organ damage is a very high risk. Diabetes mellitus with more than 3 major risk factors, or early onset of type 1 diabetes of long duration, more than 20 years. If you have a patient who've had diabetes for 20 years and more than 20 years, even if they are well controlled and they have no other problem, they're considered very high risk. Severe chronic kidney disease with an EGFR less than 30 milliliters per minute per 1.7 meters square, or family history with atherosclerotic cardiovascular disease, or family history with, familial hypercholesteremia with atherosclerotic cardiovascular disease, or another major risk factor. FH is familial hypercholesteremia with atherosclerotic cardiovascular disease, or another major risk factor. So if you have a patient with familial hypercholesteremia who has no atherosclerotic cardiovascular disease or no other major risk factor, we'll tell you how to calculate the risk. But only those patients with FH and disease or other risk factors like hypertension or smoking or diabetes are considered very high risk. Or a calculated score of equal to or more than 10% for a 10-year risk of fatal cardiovascular disease. So if a patient doesn't have any of the above, but you've calculated their score and they have more than 10% for 10-year risk of fatal cardiovascular disease, like a patient with severe family history, obese and a heavy smoker, you'll probably get that on an age of 65. You'll probably get that kind of risk score, and these are considered also very high-risk patients. Now we go to the high-risk patients. The second category, which is still red, are people with markedly elevated single risk factor. In particular, total cholesterol more than 310, or LDL cholesterol more than 190, or a blood pressure more than 180/110. So any of those risk factors alone, without anything else, would put the patient in a high risk category. Patients with familial hypercholesteremia without other major risk factors are considered high risk. Patients with diabetes mellitus without target organ damage and with diabetes mellitus duration more than 10 years but less than 20 years, or another additional risk factor. Moderate chronic kidney disease, EGFR between 30 and 59 per 1.7 meters square, or a calculated score between 5 and 10 for 5 and 10% for the 10-year risk of fatal cardiovascular disease. What about moderate risk? Moderate risk is young patients, type 1 diabetes less than 35, or type 2 diabetes less than 50. And please look at those ages, because you're talking here about type 1 diabetes. With the diabetes, or patients with diabetes mellitus duration less than 10 years, or patients without other risk factors, or patients whose calculated risk score is between 1 and 5% for the 10-year of fatal cardiovascular disease. And a lot of patients fall under this category, and we should be aware of them because they are pretty deceiving in clinics. You look at them and you normally would say that they are not risky. Finally, low-risk patients are those with a calculated score less than 1% for a 10-year risk of fatal cardiovascular disease. Obviously, these patients are not diabetic and don't have any of the clinical criteria that you've seen above, and who have probably cholesterol much lower than the figures mentioned above. So this is a summary of the risk score in the groups. The very high risk score above than 10%, high risk 5 to 10, moderate risk 1 to 5, low risk 1. And the score can be used to estimate the risk in patients who do not have clinical atherosclerotic cardiovascular disease or any clinical features that define a risk category. It can also be used to place a patient in a higher risk category due to combination of lipid levels and other risk factors. And I strongly urge you, dear colleagues, to perform risk scoring for patients. If you don't want to do it, teach somebody else to do it for you, including the patients can do it for themselves while they're sitting in the waiting room, or you can have a fellow do it, or you can even have a good nurse do it for you. Have it like you have somebody measure the patient's blood pressure, have somebody calculate the risk scores. You cannot go in life looking at patients and thinking that you're too clever, because none of us are. The calculator has been performed for a task. Now, the factors which can modify score risks, and these are very, very important because, and please take into consideration. The first one is a family history for mature cardiovascular disease. And we know that our chairman today, Professor Ashraf Rida, has a particular interest in people who get cardiovascular disease, men less than 55 and women less than 60. Patients who have elevated biomarkers, including ApoB, lipoprotein little a, C-reactive protein, triglycerides, very important, or atherosclerosis on non-invasive imaging. The third one is particularly pertinent for us in Egypt and is often disregarded. It's social deprivation and poverty. It's the origin of many of the causes of cardiovascular disease. You'll find poor nutrition, you'll find smoking, you'll find obesity with social deprivation. And then we come to obesity, and central obesity in particular, as measured by the BMI and waist circumference, which have to be measured in patients again. You can't just say this patient's weight is 90 kilograms. You have to have a BMI and you have to have waist circumference recorded for all your patients, and they should be in your reports, especially if you're a member of EAVA. Physical inactivity, and we know that the guidelines for healthy people recommend 150 minutes a week of brisk walking and 2 days of resistance training. LVH as a risk marker, CKD, OSA, obstructive sleep apnea syndrome, and very, very importantly, non-alcoholic fatty liver disease, NASH. So if a lady in your clinic who's a little bit overweight tells you that she has an ultrasound showing دهون على الكبد, please consider that this is a risk modifying her risk score. I will take you through this very quickly because, but I would please take a screenshot, and I'm sure all of you have it. This is basically how you look at the patients. If you look, at the total cardiovascular score. So this is the patient who's less than 1% in low risk. This is the patient with more 10% with very high risk. And you look at the level of LDL. So if you have a patient with a very low risk, but their LDL is 116 to 190, you do a lifestyle intervention and consider adding a drug if uncontrollable. Say an LDL is 180, and this patient is very low risk, you'll modify their lifestyle for a few months. And if not, you will treat. But if their LDL is above 190, you will give treatment. But here, the same level, if a patient at a very high cardiovascular risk, like somebody who's already had a stent, and their LDL is 55, you may already start, you will consider adding a drug. And here again, you see that you add drugs in the red very early on based on the risk. So the treatment is depending on both looking at the cholesterol and looking at the level of the risk. Of course, this is the primary prevention. This is the secondary prevention. So secondary prevention, almost everybody gets a drug. Some few people with very, very low LDL who might have had other things before might get more lifestyle interventions. So recommendation of goals. How low do you take these patients? In patients who are undergoing secondary prevention, who are at very high risk, you need to reduce the LDL to 50% from their baseline and their LDL cholesterol to less than 55. And this is class 1, and the level of evidence is A. Now, the same individuals who are at very high risk, but who have not had an atherosclerotic cardiovascular event and who do not have familial hypercholesterolemia, so undergoing primary prevention, should also get the same target of LDL of less than 50% and an LDL cholesterol less than 55. But here, the level of evidence is C. In primary preventions, for individuals with familial hypercholesteremia at a very high risk, an LDL, the same group, the FH at high risk, very high risk, an LDL of less than 50 and at least 55 LDL, 50% and 55, in level, a slightly weaker level of evidence, 2A and C. So these are the people in whom you want 50% reduction from baseline and an LDL of less than 55. Secondary prevention at very high risk, primary prevention at very high risk without FH, and the FH patient. Now, for patients with atherosclerotic cardiovascular disease who have had a second vascular event within 2 years, not necessarily the same as the first one. The first one might have been an MI, the second one is just like unstable angina or something completely different like a TIA. While taking maximally tolerated statin therapy, you need an LDL goal of 40 milligrams per deciliter to be considered. The class is a pretty weak class of recommendation, but the level of evidence is quite strong. For patients at high risk, that's just high risk without anything else, an LDL reduction 50% from baseline and an LDL goal of 70 milligram per deciliter, class 1A. Patients at moderate risk, an LDL goal of less than 100 should be considered, 2A, and level of evidence B. Patients at low risk, 1%, an LDL goal less than 116 may be considered. This is my last slide. This is just a summary of the treatment goals across the different categories of total cardiovascular risk. So the very high, you want to go with 50% from baseline or less than 55 milligram per deciliter, and you have them here. You have the patients who already have atherosclerotic cardiovascular disease clinically or by imaging, a score of dying or getting a fatal event in the next 10 years of more than 10%. Familial hypercholesteremia with high-risk features, severe CKD, diabetes, high-risk diabetes, which is target organ damage with 3 risk factors, or early onset of diabetes more than 20 years. High, 70 milligram per deciliter is the lower score, and familial hypercholesteremia without major risk factors, markedly elevated single risk, which is high cholesterol or very high blood pressure, moderate CKD, diabetes without target organ damage, and diabetes mellitus more than 10 years. The moderate, where you go to 100 milligrams, young patients, young diabetics with diabetes less than 10 years, and the low, we've just mentioned it. Thank you very much, and I'm happy to take any questions.
Thank you very much, Professor Dr. Hani, for your elegant presentation, and I'd like to discuss with you some important notes. For the score system you mentioned here, yes. When you read carefully the last guidelines from the papers, they classify the score system for Eastern Europe, different from Western Europe, different from Middle Europe. And Egypt is considered with the high score with Eastern Europe, with the special countries, yes. Because using the score of Western Europe as in the guidelines, it can be, as you see here, underestimate the risk of the patients in Egypt. What do you think about what I say from that? Should we have using the high risk score, and we don't depend on the intermediate score or the medium score of the European?
Thank you very much, Professor Atif. I think I'm hoping that very soon, Egyptian societies like the EVA would be able to answer that question and even put some Egyptian data, because we are different. I mean, for instance, there's a huge difference between us and Eastern Europe. Eastern Europe consumes huge amounts of alcohol. In Egypt, the whole country consumes very, very little alcohol. The levels of obesity in Egypt are very different from Eastern Europe, especially among females. We share things like high levels of smoking. We don't have genetic studies on Egyptians. For instance, we do not know exactly what is the situation of the ApoB and the lipoprotein little a in Egypt, which is, for instance, the lipoprotein little a is a huge risk factor in Southeast Asia, in the Indian subcontinent. It's a very, very difficult question. It's a very difficult question. So at this point in time, I would just like people to use SCORE. And to be honest, I would just like them to use the SCORE, which is available online. I wouldn't want them to go into the sophistication of differentiating for Egyptians whether they belong to Western Europe or Eastern Europe. It's important, but if you're not using anything at all, it doesn't really become important, right? I mean, if nobody is using any scoring, I mean, I've sat with the masters of cardiology and the beginners, and everybody just looks at the patient and says they're high risk, they're low risk, based on, without objective scoring. It takes a couple of minutes and it's enjoyable. And in the several clinics where I work, I've actually trained other people to do it for me. I can even sometimes send it to some patients who are very able with their smartphones and able, or to their children, and I let them calculate it before they come. So it's important to risk stratify patients. And when we start risk stratifying patients, we're going to see things which will probably help answer your very pertinent question. And we'll see the differences in Egyptians. And we'll see, for instance, maybe we'll see that we're getting coronary artery disease at lower risk or higher risk. We don't know. You know, it's a very difficult question to answer. And the short answer to your question is actually, I don't know. I don't know.
Thank you, Hani. Thank you, Hani.
Okay,
if there is any question from the panelists?
I think because of time, Atif, you can proceed. Yes. Take a 30-second break.
Dr. Ashraf, there is no time for another question for Dr. Hani?
Short question, Walid.
Okay, thank you, Dr. Ashraf. Thank you, Dr. Hani, for the nice presentation as usual. Just a small question regarding diabetic patients. You know, usually the issue in diabetics not always high LDL, and many of the patients, their LDL is not out of the target, and the issue usually is particle size, which is not available in most of our labs. And other issues is high triglycerides and low HDL. The question is, how do you approach in dealing with these patients with LDL is low or within the target? Do you recommend going to the risk modifiers like the ApoB or lipoprotein little a, or just depend on the duration of the diabetes and the target organ damage presence to refine the risk stratification of such patients?
Thank you very much. I'll just take you very quickly back to the slides. Patients with diabetes mellitus here, patients with diabetes mellitus with target organ damage or more than 3 other major risk factors or early onset of diabetes are very high risk, regardless of the lipid level. So if you have a patient with 21 years of diabetes with an LDL of 60, this is a patient at very, very high risk. Patients at high risk include diabetics who don't have target organ damage or who've had diabetes between 10 and 20 years or additional risk factors. These are considered high risk. While young diabetics, either type 1 less than 35 or type 2 less than 50, or those who've had diabetes less than 10 years, no target organ damage whatsoever, regardless of the level of cholesterol, are considered at moderate risk.
Yes.
I hope this is the answer.
Thank you, Professor Hani.
Thank you so much.
We will proceed to the next session, and thank you very much.
So welcome back again, and I have a pleasure to introduce the second session, Professor Dr. Mohammed Al-Nu'mani, and I will take this opportunity to congratulate him for the as a head of cardiology department, Menofia University, and I wish him best of luck. I'm sure cardiology department, Menofia University will progress a lot under his head supervision. So Professor Mohammed Al-Nu'mani will present to us the diabetic patient with heart failure special consideration. Dr. Mohammed, تفضل.
Bismillah ar-Rahman ar-Rahim. Professor Ashraf Rida, many thanks for the nice introduction, and thanks again for the generous invitation for me to participate in this second elegant wave in 2020. And my sincere thankfulness and congratulations for IAVA board for selection of highly potential targets and subjects in this year. In my presentation, I will try to handle, in continuation with the previous wave, an important target, which is diabetic heart failure patient, a special consideration. I will start with a short introduction. Type 2 diabetes is a major and independent risk factor for both microvascular and macrovascular complications. Endothelial dysfunction is common to microvascular and macrovascular events, leading to many target organ damage. One of the most important is myocardial infarction and heart failure. Diabetes is associated with significant loss of life years, and this is true for both women and men, and for vascular and non-vascular events. On the average, about 50 years old male with diabetes, but no history of vascular disease, 6 years younger at the time of this when compared to the counterpart without diabetes. So diabetic complications subtracts about 6 years of the expected life expectancy of each diabetic patients. Diabetes constitutes one of the most important comorbidities in heart failure patients, in addition to COPD, renal insufficiency, anemia, and depression. Diabetes and heart failure act like two important monsters. They are deteriorating each other's. Diabetes may induce diabetic cardiomyopathy, irrespective of ischemic heart disease, myocardial dysfunction, abnormal calcium signaling, oxidative stress, RAS activation, atherosclerosis, coronary artery disease, and worsening of the renal function. On the other hand, heart failure may be associated with incident diabetes or worsening of the present diabetes, or sympathetic activation, RAS activation, and worsening of the renal function. People with diabetes have 2 to 5-fold higher risk of developing heart failure, and the diabetes confers a 60 to 80% of greater probability of cardiovascular death and all-cause mortality in those with established heart failure. Diabetes is associated with a worse prognosis in patients with heart failure, and this is more evident and pronounced in diabetic patients with heart failure when compared to non-diabetic populations with heart failure. And this is true for both HFpEF and HFrEF with diabetes when compared with HFrEF and HFpEF without diabetes. Insulin resistance and diabetes are risk factors for developing heart failure. Surprisingly, it was found through different meta-analyses that hemoglobin 1C more than 10% have a 4-fold increase in heart failure incidence when compared to hemoglobin 1C less than 6.5. Actually, this is a disappointing slide and a disappointing fact. When you know that intensive and tight glucose control in your diabetic patients and heart failure only associated with reduction in major adverse clinical events and myocardial infarction, but unfortunately, it is not associated with improvement of incidence of death, cardiovascular death, stroke, or heart failure. HbA1c and the outcomes, as we see in heart failure and the diabetic population, constitutes what's called the U-shaped relationship, with the optimal glucose control is in the middle or the third quartile between 7.1 and 7.8. Higher levels of HbA1c are associated with increased mortality. Also, lower levels are associated with increased risk, may be attributed to reflex sympathetic overstimulation in those patients. Previous cardiovascular outcome trials have not shown a benefit for heart failure outcomes, and this was true for DDP4 antagonists. Some members of GLP-1 receptor agonists early in the studies before the available proof, which I will show in the following slides, and thiazolidinediones, which are considered contraindicated drugs to be handled in diabetic patients with heart failure. Diabetes with heart failure, what's our checklist? What I have to monitor or what I have to avoid? Treat heart failure in diabetic population with the same way as persons without diabetes, but with a special consideration. Metformin recommended if eGFR more than 30 milliliter per minute. If eGFR less than 60, use renin-angiotensin aldosterone system or sacubitril valsartan blockade carefully. Don't use TZDs or thiazolidinediones. Avoid saxagliptin in patients with heart failure and diabetes. Also, diabetes alone, irrespective of ischemic heart disease, may induce diabetic cardiomyopathy with 2 to 4-fold increase in the incidence of heart failure. What are the independent risk factors for heart failure in diabetic population? The proved factors are elevated HbA1c and albuminuria. Underlying ischemic heart disease should be ruled out. Anti-hyperglycemic safety concern in diabetic population. The DDP4 inhibitor saxagliptin was proved to increase since many years to increase the incidence of heart failure hospitalization by about 27%, and it is considered one of the risky drugs to be avoided in patients with heart failure and diabetes. Also, incretin-based therapies proved that, as we said, saxagliptin increases the heart failure hospitalization. GLP or glucagon-like peptide receptor agonist showed superiority in comparison to the placebo in terms of reduction of MACE. Also, GLP-1 receptor agonist meta-analysis in many trials decreased major adverse clinical events by 10% and mortality by 12%. Canavas hospitalization for heart failure, where canagliflozin reduced the heart failure hospitalization when compared to the placebo, and this was significant in favor for Canavas trial and canagliflozin. Cardiac biomarkers, canagliflozin delays the rise in serum N-terminal proBNP and high sensitivity troponin I for 2 years follow-up in comparison with the placebo. What are the recent data in the previous 2 or 3 years? One of the most impressive data are data derived from the EMPA-REG outcome and heart failure data. What are the heart failure and the diabetes data in the EMPA-REG outcome? EMPA-REG outcome proved the favorable effect of empagliflozin in addition to the standard care in reduction of 3 primary points of major adverse clinical events by 14%, reduction of cardiovascular death in diabetic patients with heart failure 38%, decreasing all-cause mortality by 32%, and reduction of heart failure hospitalization by 35%. Also, the interesting outcome in this trial, the favorable effect of empagliflozin in heart failure hospitalization or cardiovascular death, it is still working and is still validated in all the study subgroups, whether the patient is taking insulin or not, taking ARBs, ACE inhibitors, diuretics, loop diuretics, or MRA, or not taking these medications. So the favorable effect is valid in all the study subgroups. The EMPA-REG outcome, favorable data and impressive data summary are 34% reduction of heart failure hospitalization, 39% of heart failure reduction of heart failure hospitalization or death from heart failure, 35% reduction in heart failure hospitalization alone, 11% reduction in all-cause hospitalization, and 30% reduction in investigator-reported heart failure, and 31% reduction in investigator-reported serious heart failure. The second landmark trial published in the last year is EMPEROR-reduced trial, and it is one of the landmark guideline-changing trials. about 50% of the people included in embryo-reduced we have diabetes and heart failure with reduced ejection fraction. In embryo-reduced, empagliflozin achieved successful action in the primary endpoint by reduction of heart failure hospitalization and the cardiovascular death is the primary endpoint, and there were a reduction of 25% relative risk reduction and 5.2 absolute risk reduction in favor of empagliflozin versus placebo. Component of the primary endpoint, empagliflozin successfully reduced achieved the primary composite outcome of reduction of heart failure hospitalization and the cardiovascular death, and those significant for empagliflozin when compared to the placebo. Also, interestingly, the favorable effect of empagliflozin versus placebo is still present in all the study subgroups, namely patients with or without diabetes, irrespective of the age and gender of the patients, and race and body mass index, and the baseline eGFR. Also, previous heart failure hospitalization or etiology of heart failure or NIHA functional class or heart failure physiology, use of mineralocorticoid or not use it. So the favorable effect is still working and validated in all the study subgroups. Also, empagliflozin reduces total hospitalization for heart failure first and recurrent in hierarchical endpoint and was significant for empagliflozin when compared to the placebo. Also, the key secondary endpoint, which is adjudicated total hospitalization for heart failure, is reduced in favor of empagliflozin versus placebo. The key secondary endpoint, which is eGFR slope, is favorably reduced after initial increase in favor of empagliflozin when compared with the placebo. So, in embryo-reduced trial, empagliflozin achieved all the primary and secondary endpoints. Reduction of composite cardiovascular death or heart failure hospitalization, reduction of total first and recurrent heart failure hospitalization, and the slope of decline of glomerular filtration rate over time. What is the second member in this group proved to have an evidence and validated by the guidelines and have an FDA approval very recently in the treatment of heart failure in diabetic and non-diabetic population. Data are derived from two important landmark trials, which are the CLEAR-TIMI 58 for dapagliflozin and DAPA heart failure. And in very few slides, I will highlight shortly the impressive data of such two trials. Dapagliflozin in the CLEAR trial, dapagliflozin patient has significant reduction in heart failure hospitalization death and fewer MACE events compared to the placebo. Also, for patients with type 2 diabetes and HFrEF, the cardiovascular benefits of dapagliflozin appear early in terms of heart failure hospitalization and the cardiovascular death alone and all-cause mortality. Also, there is reduction of the renal composite endpoints and renal specific composite endpoints without cardiovascular death in favor of dapagliflozin versus placebo. The last landmark trial is DAPA heart failure, which is a guideline-changing trial. In the primary composite endpoint, cardiovascular death and hospitalization and urgent heart failure visit were significantly reduced in favor of dapagliflozin when compared with the placebo. Also, cardiovascular death is significantly reduced in both diabetic and non-diabetic population with heart failure in comparison to the placebo. Worsening of heart failure event and cardiovascular death or heart failure hospitalization, both in diabetes and non-diabetes, were favorably reduced in favor of dapagliflozin when compared to the placebo. Also, total heart failure hospitalization and the cardiovascular death, including the first and the repeat hospitalization, both are favorably and significantly reduced in diabetic and the non-diabetic population when compared to the placebo. Interestingly, the dapagliflozin arm have clinical meaningful change in the symptomatology expressed by improvement of the quality of life expressed by Kansas City Cardiomyopathy Questionnaire, achieving more than or equal 5 points achievement and improvement in the dapagliflozin arm, a change in the quality of life when compared to the placebo. And this was interestingly validated in both diabetic and the non-diabetic population having heart failure with reduced ejection fraction. Also, Worsening of the renal function was in favor of the dapagliflozin when compared to the placebo, and this was true for diabetes and non-diabetes having heart failure. All caused this or were also significantly reduced in favor of the dapagliflozin in diabetic and non-diabetic population. Diabetes have a specific consideration in the last guidelines and the risk stratification, as mentioned by Professor Hani Raghi in the previous presentation. Diabetes can impair a very high risk profile of the patient if the patient is diabetic with established cardiovascular disease or have another organ target organ damage or other major 3 cardiac risk factors or early onset diabetes with long duration more than 20 years. Diabetes may be in high risk patients if the diabetes duration more than or equal 10 years without target organ damage or plus any other single risk factor. Or it may be in the moderate risk group in younger patients with type 1 diabetes less than 35 years of age, or type 2 diabetes less than 50 years of age, or diabetes duration less than 10 years but without other risk factor or target organ damage. Here is the famous slide, the algorithm and the old rationale for the management of HFrEF patients. And this is a well-known slide for all of us. The question here, I have to wait in 2020 to start the favorable medication with favorable effect on the outcome and the mortality and the cardiovascular death and hospitalization till the third step, or I can target these important medications like ARNI and the new visitor or new member SGLT2 inhibitors from the start. This is that I will highlight in my remaining few slides. The rationale of and the concept of management of diabetes have been changed significantly since 2016 up to 2021. It changes significantly from just the concept of glucose lowering to considering that empagliflozin or liraglutide, which is the GLP-1 receptor agonist to reduce mortality, then in 2018 incorporate an agent proven to reduce cardiovascular events and mortality. Then in 2019, a GLT2 inhibitor or GLP-1 receptor agonist with demonstrated cardiovascular benefit or are recommended as level 1 recommendation. In 2020, GLT2 inhibitors or GLP-1 receptor agonists demonstrated cardiovascular death benefit are recommended independent of HbA1c level. And the European Society of Cardiology since 2 years in 2019 have issued this important algorithm for the management of diabetic population. If the patient is type 2 diabetes and drug naive, not taking any anti-diabetic drugs before and in high risk or very high risk or proved atherosclerotic cardiovascular disease, I have to start directly from the beginning with a GLT2 inhibitor or GLP-1 receptor agonist. If the patient is still not controlled according to the HbA1c level, I shift to add metformin, and I can add a third step if the HbA1c level are not achieved. Type. On the other hand, if the patient is type 2 diabetes and already on metformin, I shift directly to a GLT2 inhibitor or GLP-1 receptor agonist if the patient is having atherosclerotic cardiovascular disease or at high or very high risk. And I up-titrate according to the HbA1c control. This is a very important slide, published just few days in 2020 in January. And the great achievement in this slide is the agreement and the close agreement in opinion between the European Society of Cardiology and the American Diabetes Association. American Diabetes Association last month proved that if you have a high risk or very high risk patients or proved atherosclerotic cardiovascular disease or patient with chronic kidney disease or patient with heart failure and diabetes, you should start early from the beginning with either a GLT2 inhibitor or GLP-1 receptor agonist and then up-titrate other anti-diabetic medications. Since the release of 2016 guidelines, many gaps have been identified in the management of heart failure patients, as we all know. And many trials have been proved in diabetes, in heart failure, like DECLARE TIMI 55, DAPA heart failure, EMPA-REG outcome, EMPEROR reduced Soloist heart failure, Paradigm heart failure, and Pioneer heart failure, Pioneer extension, Paradigm heart failure subgroup analysis, transition study, and the remodeling studies, proof heart failure, evaluate heart failure, and finally, Galactic heart failure, evaluating a new member, which is omecamtiv mecarbil in management of heart failure. What is the impact of these gaps and these many promising and landmark trials in our recent practice in management of HFrEF patients? This is what's new in 2020. First, what are the Fantastic Four? This is another important editorial published since about 30 days last month, addressing 4 important drugs in the management of HFrEF patients and proposing an important algorithm for the management of HFrEF patients. This editorial recommends and states that all patients with HFrEF should be started early from the beginning with the 4 fantastic drugs or the 4 essential drugs or 4 pillars, which are ARNI, mineralocorticoid antagonists, beta blockers, and SGLT2 inhibitors. And according to the individual data and the characteristics, we have to do tailoring or fine-tuning of each patient according to the underlying pathophysiology and the other circumstances. For example, in AF patients, I can add anticoagulant digitalis or refer to pulmonary vein isolation for wide QRS complex and left bundle branch block. I can consider CRT heart rate more than 70 beats per minute, and in sinus rhythm, I can add ivabradine for congestion loop diuretic or thiazides. If recent decompensation and advanced heart failure, I can add one of the new members, which are vericiguat, which is an oral soluble guanylate cyclase simulator, have an entropic effect, and omecamtiv mecarbil, which is a selective myosin activator. Other drugs, including ferric carboxymaltose, if ferritin is less than 100 or transferrin saturation less than 20. ACE inhibitors or ARBs are considered substitutes for ARNI if there is a cost issue. Hydralazine nitrate in self-identified plaques, mitral edge-to-edge repair if there is disproportionate mitral regurgitation. The interesting for the first time is to come with the European and the American guidelines to have the same concept and the same agreement in the same time. دايما احنا متعودين ان يبقى في جاب في الاجريمنت between the European guidelines and the American guidelines. This is another important expert pathway just published since a few days in the time of the last editorial of the European Society of Cardiology. Shortly, and I will finish in 3 slides, the important recommendations of the American College of Cardiology states that initiation of the 4 pillars or the 4 fantastic drugs, initiation of beta blocker is better tolerated in patients with dry heart failure, HFrEF, and an ACE inhibitor, ARB or ARNI, when the patient is wet. The decision pathway that most important states that, frankly, SGLT2 inhibitors should be considered in HFrEF patients with the other 3 pillars with NIHA class 2 or 4 patients. Interestingly, it states that an ideal time to consider therapy optimization is during hospitalization for HFrEF. ده in contrast to the opposite أو the old rationale إن أنا استنى for 3 or 2 steps وبعد كده to try these important medications later on. Finally, in conclusion, my take-home message: heart failure in diabetics is still under-recognized and misdiagnosed. This has significant clinical implications, and the prognosis of untreated or undertreated heart failure is poor, and yet very effective proven therapies are widely available to most people. Diabetes can cause heart failure independently of ischemic heart disease by causing diabetic cardiomyopathy, and this manifests in the setting of normal or reduced ejection fraction. So, diabetic cardiomyopathy may be starting process early, even before severe deterioration of the ejection fraction. Heart failure with diabetes should be treated similarly to heart failure without diabetes, but with some special consideration as mentioned. The presence of diabetes should not affect the decision for treatment of heart failure. Finally, this is my last slide. Comorbidities such as renal dysfunction and propensity for hyperkalemia are more prevalent in people with diabetes and may influence heart failure drug doses and the monitoring of therapy, but not therapeutic targets. The totality of evidence available in 2020 is to suggest the patient with HFrEF with and without diabetes should be treated early with combination of the 4 drugs, which is ARNI, beta blockers, mineralocorticoid antagonists, and SGLT2 inhibitors as the newest member. In order to benefit from the substantial and sustained reductions of mortality, heart failure, hospitalization, and symptoms, the important task now is to ensure access to this evidence-based therapy for all HFrEF patients. And finally, thank you.
Thank you, Professor Noumani. Actually, you can stop sharing the slides now. And actually, Dr. Mohammed, you extensively cover the subjects of today's meeting, which our targets actually, because you know this wave is regarding the diabetic patient, risk stratification of the diabetic patients, how to manage to prevent the cardiovascular and renal outcome. What about heart failure in diabetic patients? And actually, I noticed from your presentation that there is many mechanisms that can lead to heart failure in the diabetic patient. And maybe it is independent even of the hyperglycemia itself, like the cardiomyopathy, like the multiple risk factors. And that's why start early with the drugs that can prevent this heart failure is very important. And you nicely illustrated the CLARE study, dapagliflozin, which is used in, which is essentially a primary prevention study, because most of the patients are not having actually established ischemic heart disease. It seems that we as cardiologists have to be more in contact with the diabetic patients, more in contact with the drug regimes, to be sure that they are not only good controlled as regards hyperglycemia, but also to be sure that they are prescribed the drugs that can cause cardiovascular protections. And if any questions from the panel for Professor Mohammed, kindly, we have a few minutes for discussion. And if no questions, let me ask Dr. Mohammed about the...
دكتور أشرف لو تسمح لي حضرتك دكتور محمد مرة تانية congratulations يا فندم، ألف مبروك وربنا يجعلها في يدك لا في قلبك زي ما بنقول. في question دكتور أشرف من الأودينس، لو حضرتك تقراه يا فندم لدكتور محمد، احنا يعني ما خدناش بالنا منه من حوالي 5 دقايق. هو بيقول what about the side effects like polydipsia, dehydration, diuresis that occur to patients on dapagliflozin treatment not taking diuretics? ده question من some colleague called E. Samir.
اوكي اتفضل دكتور محمد.
Actually يعني this is a very important question، لأن هو كل الهازارds أو الفير اللي كانت في اول الايرا بتاعه الGLT2 انهبيتورز عموما، واحنا هنقول دلوقتي الدابا لان هو يعني ابروفد بالاف دي ابروفال، وان كان في برضه ترايلز كتير جدا فاليديتنج الامباجليفلوزين، بس الدابا هو اللي ابروفد في يعني في التريتمنت دلوقتي، حتى فاليديتد بالنسبه للشركه نفسها انها تتكلم عليه كوان اوف ذا لاينز اوف تريتمنت. الفيرز اللي كانت بتحصل مينلي هي اليورينري تراكت انفكشن، ويمكن يعني قالوا بعض الحاجات الخاصه بالامبيتوشن، لقوا ان ده مش سيجنيفيكانت خالص في الارم اللي خد داباجليفلوزين فيرسس الارم اللي خد البلاسيبو. وطبعا الموضوع هيعتمد على شويه انستراكشنز للبيشنتس، يعني سم اديوكيشن، نعتمد شويه على الكير بالهايجين اكتر، ده يعني كلها بحاجات نقدر ايشوز نحلها. الحاجه الكويسه جدا في المجموعه دي عموما انها بتشتغل ايوجلايسيميك دراجز لما يبقى في هايبرجلايسيميا، بمعنى هي مش هتعمل اوفر دايوريسيس ومش هتعمل هايبوجلايسيميا، وما بتشتغلش بالطريقه دي خالص الا عند جلوكوز ليفل معين، فبالتالي هي نوت يعني اكتنج اون ذا بنكرياس زي مثلا مجموعه السلفونايل يوريا، فهي بتشتغل على قد المتاح. فبالتالي لو عيان مش دايابيتك خالص زي نص العيانين مثلا اللي كانوا في الامبريو ريديوز او في الدابا هارت فيلير، كل نص العيانين اصلا ما كانوش دايابيتك. ويمكن الفيفورابل افكت اللي اكتشفوه في الديكلير زي ما الدكتور اشرف قال، ويمكن في الامباريج اوت كام، هي اصلا كانت ترايل معموله للدايابيتك بوبيوليشن، هم اكتشفوا بالصدفه في ناس نون دايابيتك ان الفيفورابل افكت ده موجود في النون دايابيتك اللي عندهم هارت فيلير. فما فيش فير من ده خالص، بس هو النقطه اللي لازم تؤخذ في الاعتبار، هل البيشنتس بياخد انتي دايابيتك او جلوكوز لورنج دراجز اذر ذان جي ال تي 2 انهبيتورز؟ هل بياخد انسولين؟ هل بياخد سلفونايل يوريا؟ لان هنا المعادله هتختلف شويه، هيبقى في سام سورت اوف سينرجيزم. يعني لو البيشنت بياخد انسولين او بياخد سلفونايل يوريا ممكن يحصل له هايبوجلايسيميا عن طريق السينرجيزم، فما تعتمدش هنا ان الديفولت افكت بتاعك هو على الجي ال تي 2 انهبيتور. فهو هيبقى محتاج سام كوشس يعني في المانجمنت، وزي ما بروفيسور اشرف رضا قال هيبقى محتاج برضو كو ارينجمنت مع الدايابيتولوجيست. يعني لو البيشنت بيتابع مع دايابيتولوجيست انا هقول له انا اي ام فيفرنج ان ده يبقى one of the drugs of my patients، وكمل انت الباقي لو هو البيشنت كده. وان كان احنا الايرا بتاعت الهارت فيلير والدايابيتس I think in the coming يعني few years I think ان احنا ككارديولوجيست we have to treat our diabetic patients. حتى الاي دي اي نفسها ابتدت تعمل ريسك ستراتيفيكيشن للبيشنتس بتوعها، عكس ما كان الكونسبت زمان. الريسك ستراتيفيكيشن ده كانوا بيعتبروه حاجه خاصه بتوع الكارديولوجي وان هم عايشين في دنيا لوحدهم. لا، ده الاي دي اي لاول مره خدت الراشونال بتاع اليوروبيان سوسايتي اوف كارديولوجي وابتدت تعمل نفس الستيتمنتس. وعشان يجيبوا من الاخر خالص زي ما احنا قلنا في اخر البرزنتيشن، يمكن الامريكان سوسايتي اوف كارديولوجي والامريكان واليوروبيان سوسايتي اوف كارديولوجي اتفقوا في نفس التايم في نفس الشهر على حاجه واحده، ودي عمرها ما كانت بتحصل. واكيد حضراتكم فاكرين الجايد لاينز اللي كانت طف جدا بتاعه الهايبرتنشن، احنا قعدنا سنه فيري اكسنتريك بالنسبه للتارجتس بتاعتنا، وبعد كده جت اليوروبيان جايد لاينز عدلت الامور. فيعني اي ثينك ان هو ما فيش فير خالص من الادويه دي، بشرط ان انا تو نيجوشيت مع البيشنتس بتاعي لازم سيلف اديوكيشن، ولازم يعني اكلف خاطري شويه، يعني اعمل شويه انستراكشنز للبيشنتس مع البيرسونال هايجين والفولو اب. ويعني انا برضو براكتس وايز الحقيقه الانسيدنس اوف ذي سايد افكتس از تقريبا نيل في اغلبيه البيشنتس. ده this is my overview يعني.
ثانك يو.
شكرا دكتور محمد. في كومنت بس دكتور اشرف if you allow me. دكتور محمد يعني thank you for the nice presentation، يعني very elegant presentation as usual. حضرتك وريت سلايد مهمه جدا، بس انا هايلايت بس او ستريس عليها، اللي هو اليوروبيان جايد لاينز اللي هي اون دايابيتس اند بري دايابيتس، ان البيشنت اللي هو دايابيتيك اللي هو اوريدي بياخد هايبوجلايسيميك دراج وعنده هاي كارديوفاسكولار او فيري هاي كارديوفاسكولار ريسك انديكيتد كلاس 1، ان انا اشفت على الميديكيشنز اللي زي الاي سي جي ال تي 2 انهبيتور او الجي ال بي 1، عشان دي ممكن بعض البيشنتس حتى كان ارجو ان يقول لك انا البلاد شوجر بتاعي كنترولد على الميديكيشنز اللي باخدها، وات ايفر كان بياخد ميتفورمين او سلفونايل يوريا او الاي 1 سي بتاعي في التارجت. انما مع ذلك الجايد لاينز اكدت كلاس 1 ان هو البيشنت از لونج ان هو هاي ريسك او فير هاي ريسك، انا شفت على الدراجز اللي هي بروفد ان هي ليها امباكت على الكارديوفاسكولار ريسك.
انا عايز بس هنا وليد، يعني معلش هقطع كلامك ثانيه واحده ان فيري شورت. هو لو البيشنت انتي هايبر جلايسيميك دراجز نايف I will start directly GLT2 inhibitor or GLP1 receptor. لو هو اوريدي اون ميتفورمين I will add on ميتفورمين.
اد بالظبط،
مش هعمل شيفت.
طب هو الفكره بقى لو هو كنترولد، السؤال اللي هو كنترولد على الميتفورمين والاي 1 سي بتاعه في التارجت، برضو اد على الميتفورمين برضو بالظبط،
او عنده كرونيك كيدني ديزيز او هارت فيلير عشان استفيد من السرفايفل بينيفيت. واحنا اتفقنا ان الميتفورمين مش هايبوجلايسيميك دراج ولا الاس جي 2 انهبيتور هايبوجلايسيميك دراج.
تمام. ثانك يو فيري ماتش.
شكرا دكتور محمد, and I think we can now take a 30-second break to prepare for the next sessions. So stay with us.
Many thanks, Professor.
Welcome back, Yasser Hussain, and greetings for Professor Ashraf Rida and for all the professors and all the friends here. I think we have a very hot session today, and if anyone outside the field, I think he would say that there is a mistake in the title of the lecture, or it should be not presented by a cardiologist. We are the diabetologist, we are the nephrologist, but I think as regard optimization of diabetes mellitus treatment protect kidney. زي ما بيقولوا ايه اللي جاب القلعه جنب البحر. I don't think so. There is a magnificent link between the three entities or the three diseases, and I think Professor Ahmed very well elaborates with the recent guidelines, the magnificent and the robust recent trials, how they do link. Please, Professor Ahmed, and welcome, Dr. Muhammad Tabla. I have just seen you have a comment to introduce Dr. Dari.
Okay.
Okay. Dr. Bendari.
Okay, thank you, Professor Yasser, for this kind and very nice introduction. Thank you, Professor Ashraf Rida and the IAVA board for inviting me. It's always a pleasure to be with you all. As you said, Professor Yasser, if you asked me just a few years ago, can you speak about glucose control and protection of the kidney? I'll say, no, you are joking. This is the job of the diabetologist. And today, after the introduction of the recent newer anti-diabetic drugs, I'm here, a cardiologist, speaking about the optimization of glucose control to protect the kidney. Can you imagine it? Can you feel it? Okay, let's start by looking to this very nice picture. This is the diabetic glomerulus. If you look at the picture number A, as you see, you will see a normal, beautiful glomerulus. And then, if you look to the picture number B, you will see the early stages of diabetic nephropathy, which is mesangial expansion. If you look to the picture number C, you will see the nodularity, and then the famous Kemmelsteil-Wilson nodules after accumulation of mesangial matrix. And then you will see this poor picture, these aneurysms, the plasmatic insudation, and the ugly obsolescent glomerulus. The glomerulus is totally obliterated by this poor mesangial expansion. First, before going deeply into my presentation, I'd like to highlight some common misconceptions. In the early stages of teaching, we have been told that microalbuminuria is an early clinical finding of diabetic glomerulopathy. And then we have been taught that this albuminuria could regress, but recently we knew that it could regress. Most importantly, regarding the glomerular filtration rate, the recent data proved that it shows a progressive decline across the stages of chronic kidney disease. And interestingly, some patients develop progressive decline of GFR before even the onset of albuminuria. And accordingly, now worldwide, we are looking to rapid GFR decline as a greater and more important prognostic marker for diabetic kidney disease than this albuminuria. So you will find that most, if not all, new trials testing the newer medications of anti-diabetes looking to this important endpoint, the rapid GFR decline. It's not at all acceptable to speak about glucose control and protection of the kidney without speaking about or referring to the intensive blood glucose control. And how could the benefit differ between type 1 diabetes and type 2 diabetes? In type 1 diabetes, intensive glucose control, according to the data coming from the DCCT trial with follow-up of approximately 9 years, patients undergoing intensive glucose control experienced significantly lesser rates of microalbuminuria and progression of kidney disease compared to those patients undergoing the conventional strategy. Similarly, in patients with type 2 diabetes, according to the data coming from the famous UKBDS, patients undergoing intensive blood glucose control showed a significantly lesser propensity to develop microvascular disease, including diabetic kidney disease, compared to patients with conventional strategy. As you see here, the relative risk reduction was 25%. The p-value was significant. Therefore, all the guidelines, whether the ADA, the International Diabetes Federation, IDF, the Diabetes Canada, and the European Association for the Study of Diabetes, recommends a hemoglobin A1C target of 7% or less. The evidence here, it should be noted that the evidence here is stronger for patients with type 1 diabetes compared to patients with type 2. But, and I'll say it again, but you should consider always the danger of hypoglycemia when you are going for the strict glycemic control strategy. This is simply because hypoglycemia is a very important, significant predictor for future all-cause mortality. For example, looking at data coming from the DCCT trial, as you see, when you go lower in your hemoglobin A1C, the potential for hypoglycemia increases significantly. To corroborate these findings, let's look to this very important slide. This slide subjects the trials comparing the intensive versus conservative glucose control, whether the UKBDS, the ACCORD trial, the ADVANCE trial, and the VEDIT trial. You, at the first sight, will note from this slide that intensive blood glucose control has led to significant reduction in the microvascular endpoints, specifically microalbuminuria and the development of end-stage renal disease. However, as we all know, these trials have not proven that intensive blood glucose control could lead to a significant benefit in terms of macrovascular complications such as MI, strokes, and so on. Also, it's not acceptable at all to consider glycemic control as the only way you could do to the patient in order to prevent the development of diabetic kidney disease or the progression of kidney disease in general. You should look for glycemic control as just a part of the big picture. You should do intensive blood pressure control. You should prescribe RAS inhibitors for those patients with microalbuminuria. You should not forget the glucose control. You should not forget to stress on the adequate and proper lifestyle modifications. However, doing proper science is good. Back in 2008, you remember the row after rosiglitazone has led to some serious adverse cardiovascular events. The US Food and Drug Administration has mandated that any newer anti-diabetic drug should undergo what we call a CVOT or cardiovascular outcome trial, just to prove the safety of any newer anti-diabetic drug upon the cardiovascular outcome. And actually, this was a new era in the diabetology, and we have, as cardiologists, entered the landscape of diabetology from this decision. And here we should mention the SGLT2 inhibitors. And I'm asking a question. Was this a serendipitous story? Was we lucky to have these molecules entering a cardiovascular outcome trial? Back to the basics, the SGLT2 inhibitors block the SGLT2 receptors, which are located in the S1 segment of the proximal convoluted tubules. These receptors, as you see, are responsible for reabsorption of more than 90% of glucose filtered from the glomerulus. And this could logically lead to glucosuria and natriuresis. This has been theoretically translated into a reduction, as we see, in the plasma glucose, in the body weight, in the blood pressure, and we, as a result of this, will have a higher delivery of sodium to the distal nephron, and this could lead to a vasoconstriction in the afferent arteriole, leading to reduction in the intraglomerular pressure, which is the forcing power for the development of proteinuria, and we will come to this later. If you have a bird look from above to the main heart and renal outcomes in the cardiovascular outcome trials of different SGLT2 inhibitors, whether the EMBARIG outcome trial, the CANVAS trial, and the DECLARE-TIMI 58 trial, you will see, as here, a consistent finding towards a significant reduction in the renal outcome, which are usually doubling of serum creatinine or development of end-stage renal disease and either cardiovascular or renal death. So we have here what we call a signal towards a benefit regarding the renal outcome in all CVOTs of the recent SGLT2 trials. And this opens the door for an important question. Why not to treat those patients with diabetic kidney disease with severely increased albuminuria with SGLT2 inhibitors just, and I'll say it again, just for the purpose of prevention of the progression of kidney disease? And this was the question answered in 2019 by the landmark practice-changing CREDENCE trial. In short, in CREDENCE trial, which was a double-blind randomized trial, more than 4,000 patients aged more than 30 years with hemoglobin A1C above 6.5 and less than 12, with chronic kidney disease and estimated GFR ranging from 30 to 90, on stable RAS blockers for more than or equal to 4 weeks, were randomly assigned to receive either canagliflozin 100 milligrams or matching placebo. And sit down for this. In this trial, we had a significant 30% reduction in the primary outcome, which was the development of end-stage renal disease, doubling of serum creatinine, or even renal death. The authors in this important landmark trial concluded that in patients with type 2 diabetes and kidney disease, the risk of kidney failure and cardiovascular events was lower, significantly lower in canagliflozin group than in the placebo group over a median follow-up of about 2.6 years. The second member joining the train was the dapagliflozin in the landmark DAPA-CKD trial, which has been recently published in 2020. In this trial, which was also a double-blind randomized trial, again, in a similarly designed fashion, more than 4,000 patients with diabetic and non-diabetic, and this is a major difference between DAPA-CKD trial and CREDENCE trial. Here, the investigators allowed the inclusion of patients with chronic kidney disease due to reasons other than diabetes. Those patients were randomized between receiving dapagliflozin and placebo. And again, in a similar result, we had a significant more than 35% relative risk reduction in the primary outcome, which was a decline of more than or equal to 50% in the GFR, new end-stage renal disease, renal or even cardiovascular mortality. The authors concluded, similarly to the CREDENCE trial, that among patients with chronic kidney disease, sit down for this, regardless of the presence or the absence of diabetes, the risk of a composite of a sustained decline in GFR, end-stage renal disease, death due to renal or cardiovascular cause was significantly lower in dapagliflozin compared to placebo. But how do these molecules benefit the kidney? There are a lot of theories. However, the most acceptable two are as follows. Number one, again, the tubuloglomerular feedback. This is the picture of patients with diabetic glomerulus. We have a dilated afferent arteriole, increasing the intraglomerular pressure, leading to increasing of the force that is forcing the proteins across the glomerular membrane barrier. With the use of SGLT2 inhibitors, there is excessive delivery of sodium to the distal nephron. Please note that the sodium is a very valuable substance to our body. So the distal nephron sends a feedback to the afferent arteriole telling it to vasoconstrict. Please, I am receiving a lot of sodium. Please do a vasoconstriction in order to save this loss. We have here accordingly an afferent arteriolar vasoconstriction leading to reduction in the intraglomerular pressure, which is, as I have said few seconds ago, the driving force for proteinuria, and then we have a decrease in proteinuria. Importantly, we have a theory called that SGLT2 inhibitors could be seen as the beta blockers of the kidney. And we can explain it in just 1 minute. This is a healthy kidney. You have a sodium and glucose reabsorbed through the SGLT2 inhibitors in the proximal convoluted tubular cells. This sodium has to be expelled out of the cell. The cell does not like the sodium to be present intracellularly. The sodium is expelled out of the cell through the sodium-potassium pump, which of course uses ATP or energy. Around the proximal convoluted tubules, we have the fibroblasts secreting the erythropoietin. With diabetes, there is excessive reabsorption of sodium and glucose, so we should expel this sodium outside of the cell. With excessive use of energy essential for the sodium-potassium pump, and this creates a state of local stress or local hypoxia, leading to transformation of this functional cell to non-functional cell and a decreased production of erythropoietin, and this could partially explain the anemia in patients with chronic kidney disease and diabetes. However, with the use of SGLT2 inhibitors, we block this receptor. So we will have a lesser amount of sodium and a lesser use of energy by the sodium-potassium pump, allowing a chance for the reversible transformation of the fibroblast from the non-functional status to the functional status, leading to increased production of erythropoietin, improvement in the anemia, and improvement in the kidney function. So we can look at SGLT2 inhibitors as a molecule that conserve the energy for the kidney. But suppose that patients with diabetic kidney disease are on SGLT2 inhibitors and still not at the goal of hemoglobin A1C, and I am in need of more glucose control. Here, you should think about the GLP-1 receptor agonists. According to the data coming recently from the ADA, if you look to the algorithm put forth for managing diabetes in patients with chronic kidney disease, you will notice that if the hemoglobin A1C is above the target, you are allowed to add, in addition to SGLT2, a GLP-1 receptor agonist with proven cardiovascular benefit. Importantly, the GLP-1 receptor agonists act in a smart way. They suppress glucagon secretion from the liver, they stimulate insulin secretion from the pancreas, and they slow gastric emptying. Importantly, in a pre-specified secondary analysis from the landmark LEADERS trial, the addition of liraglutide to the already present anti-diabetic regimen has resulted in a significantly lower rates of the development and progression of the diabetic kidney disease. Look at this figure. If you look to the composite renal outcome, patients receiving liraglutide compared to patients receiving placebo had shown a significant 20% relative risk reduction in the composite renal outcome. And if you look specifically to the new onset persistent macroalbuminuria, there was also a significant 26% relative risk reduction. Not only liraglutide, dulaglutide, in a very important randomized trial published in Lancet Diabetes Endocrinology just 2 years ago, called the AWARD-7 trial, dulaglutide showed a significant reduction in the rate of the decline of GFR. And you remember, as I told you in the beginning of the presentation, that the rate of decline of GFR is more important than the development of albuminuria. The addition of dulaglutide by its 2 doses in this trial has resulted importantly into reduction of the rate of progression of the eGFR and albuminuria compared, and sit down for this, to not placebo but insulin glargine. And these are big news. I am not comparing dulaglutide in this trial with placebo. I am comparing it head-to-head with insulin glargine. To conclude my presentation, we can say that glycemic targets for patients with diabetes to prevent the progression of diabetic kidney disease is about hemoglobin A1C 7% or less. And the evidence here is stronger for type 1 diabetes compared to type 2, but always factor the risk of hypoglycemia into your judgment. Second, please don't forget the big picture of management. We have blood pressure, we have RAS inhibitors, we have lifestyles, and we have cholesterol. Importantly, in patients with type 2 diabetes who have chronic kidney disease and severely increased albuminuria despite angiotensin inhibition, the guidelines recommend treatment with SGLT2 inhibitors. It's also recommended and reasonable to use SGLT2 inhibitors in patients who have lower levels of urine albumin excretion, despite the fact that the evidence here is not strong enough compared to patients with markedly increased albuminuria. The SGLT2 inhibitors are typically added to the patient's existing hypoglycemic regimen. They are not interchangeable with other medications, and in fact, their glucose lowering effect is not that much. Till now, and I stress on this, SGLT2 inhibitors are not appropriate for patients with type 1 and chronic kidney disease. They can lead to what we call euglycemic diabetic ketoacidosis. The final 2 points is that if you are in need of more glucose lowering and more protection, please look to GLP-1 receptor agonist, and don't never forget to monitor your patient. Thank you for your listening. I was Ahmed Bindari signing off, and goodbye.
Thank you, Dr. Ahmed. Very nice. I have a question. If a patient is controlling diabetes, blood pressure, and lipids, is kidney affection is unavoidable in a diabetic patient?
Yes. Actually, if we look back to the slide I have projected about the natural history of diabetic kidney disease, the reduction in GFR is inevitable. It's an aging process, and this aging process is accelerated by the presence of diabetes. However, you could decline or decrease the rate, I'll say it again, the rate of this decline by the introduction of some medications that have been proven to control diabetes at one hand, and at the same time, they could add a benefit to the GFR on the other hand. To stress the answer to your question, sir, and I'd like to thank you very much for this question. The decline in GFR in diabetes is an inevitable event. It's part of the deal. It's part of the natural history of diabetic kidney disease. However, you could modify this rate of decline by the introduction of these drugs and looking to the big picture of control of other risk factors.
Thank you very much. Thank you.
Would I have 2 quick ones and 1 small question for sake of time? I think, thank you, Dr. Ahmed. It was a very unique journey, as usual. I think we should point out that the FDA, when addressed that should seek for safety, not only ask for safety, but also to let the design of any trial, phase 2 or 3, to be adapted to enter into meta-analysis. Second, comment that one of the important aspects of DAPA-CKD, that all the relative risk reduction we had were without including those who had deteriorated heart failure patients. They were included in the inclusion criteria. The question, you talked about the incretins, the sodium glucose transporter inhibitors. We do agree, and they are the two cornerstones or two pillars in those with established atherosclerotic cardiovascular disease or heart failure, or having high cardiovascular. But in literature, there is a window for thiazolidine dione, like the pioglitazone. When I came across the literature for this session, I found a lot of data on pioglitazone. Of course, not with those who are in heart failure, but as protection, as cardiovascular protection. The question to you, Dr. Ahmed, where is the window to put the pioglitazone, which is proved to be renoprotective, regarding the glomerulosclerosis, etc., many aspects, where to put it, despite it's not on the first line treatment in the guidelines. Where do you think about it?
Thank you very much, Professor Yasser, for highlighting this usually overlooked molecule. This molecule, if you look to the literature, have some good data regarding to the protection of the cardiorenal axis. However, as you know, and as we all know, that one of the ugly side effects of this drug is some water retention. And this is not suitable for a considerable category of patients with diabetic kidney disease, because those patients, some of those patients usually have a cardiac element, what we call the cardiorenal syndrome or the cardiorenal complex. I personally usually add this molecule if the patient is not at the hemoglobin A1C target, it has a good glucose lowering effect, this is number one, and is not showing manifestations, clinical manifestations of volume overload or congestive heart failure. However, we have no well-designed, large, randomized control trial testing this molecule against the standard of care, such as the Credence trial or the DAPA-CKD for protection of the cardiorenal axis. This is why this molecule was overlooked. مظلوم يعني.
Okay, I think if there is no questions, we can take a 30-second break to prepare for the last sessions. Will be moderated by Professor Sameh Emil, Professor Said Farag, Professor Hani Raghi, and Professor Nabil Farag. So let us take a 30-second break to prepare for the last session. Okay,
thank you.
Okay. Thank you very much for inviting me, Professor Ashraf, for this very elegant meeting. I was watching all the previous speakers, very interesting talks and a very important subject. So we'll continue about the SGLT2 inhibitor and the cardiovascular protection by Professor Ashraf Reda. And it's my pleasure to have Professor Hani Raghi, Professor Nabil Farag, Professor Said Farag with me, co-chairing this session. So start with Professor Ashraf Reda and his talk. Thank you.
Thank you, Professor Sameh. And actually, this last session is the industry-supported CME activity. And on this occasion, I would like to thank Biofactor Marcel company for supporting the IAVA CME activities. So we'll discuss, I think many presentations previously in this tonight have discussed elegantly the diabetes, the heart failure with diabetes, the renal protection with diabetes. And let me illustrate these findings, of course, with focusing on the dapagliflozin evidence this trial. So I would like to first of all to thank all the distinguished faculty, speakers, and moderators of tonight CardioRisk Wave. As you know, type 2 diabetes is pathophysiologically closely related to cardiovascular and renal events and outcome. This may be related to genetic predisposition, also due to obesity and lifestyle factors. If these two are present, the next will be insulin resistance. Of course, the body will start to compensate by some beta cell hyperplasia, but eventually this will lead to beta cell failure either early or late, leading to frank diabetes. Worldwide burden of diabetes actually is estimated to affect more than 400 million adults worldwide. The prevalence is increased, and actually it is expected that more than 600 million adults will have diabetes by 2040. So I think all of you cardiologists, prepare yourself to treat this progressively increasing burden of diabetes and cardiovascular and renal disease in the community. Diabetes is actually by itself is a cardiovascular risk factor. If you look at for example, coronary heart disease incidence, according to the level of hemoglobin A1C in this diagram, which nicely illustrated how the level of hemoglobin A1C in diabetic patients is related to coronary heart disease mortality, and even related to all coronary heart disease event rate, whether low or middle or in the high level range of hemoglobin A1C. Why diabetic can lead to heart failure? I think Dr. Noumani nicely illustrated the different mechanism of actions, but I want to illustrate that diabetes can lead to heart failure through both atherosclerotic mediated and atherosclerotic independent mechanism. Patient with type 2 diabetes at risk of heart failure, partially due to atherosclerosis event, like, for example, if he got myocardial infarctions or recurrent acute coronary syndromes, he can develop ischemic cardiomyopathy. However, patients with type 2 diabetes are also at risk of heart failure due to direct inflammatory effect of the microvascular endothelium and myocardium with subsequent fibrosis, and this is actually an atherosclerotic independent. So actually diabetes is related to heart failure, whether through atherosclerotic cardiovascular disease or even independently through inflammatory effect on the vascular endothelium and myocardial effect, diabetic cardiomyopathy, vascular endothelium. So actually, when we look at the patient with diabetes, we should expect a cardio-renal metabolic risk continuum. And this is related to the multiple cardiovascular risk factors in diabetic, like smoking, like overweight, like hypertension, dyslipidemia, in addition to increase the risk of heart failure, hospitalization, chronic kidney disease, and even atherosclerotic cardiovascular. Diabetic patients has a liability to high event rate, whether cardiorenal or atherosclerotics. And by the end of the day, you will encounter with the complications of all these parameters, leading to repeated heart failure hospitalization, progressive renal functional decline, myocardial infarction, and even mortality. If you look at the older glucose-lowering agents, actually they haven't definitively shown positive effect on the major cardiovascular events. Whether the drugs like sulfonylurea, glycosides, if we look at the ADVANCE trial, ACCORD trial, and VADET trial, and many trials of all the trials of the diabetic patients using all the glucose-lowering agents showed that these agents actually, although effective in controlling the hyperglycemia of the diabetes, but we have no evidence that these drugs are either safe or positively can affect the major cardiovascular and renal outcome of the patient with diabetes. Even when the DPP-4 inhibitors were introduced in the last few years, actually they were largely cardiovascular neutral, because as you know, with the introduction of DPP-4 inhibitors, there was the era of any new diabetic or hypoglycemic drugs should prove to be safe for the cardiac patients. There is a SAVOR trial using the saxagliptin. There is the EXAMINE trial using allogliptin and sitagliptin in the TECOS trials. Most of these trials shows neutral effect, and even the saxagliptin, as you know, in the guidelines, it's not recommended to be used in patients with heart failure. So even DPP-4 inhibitor did not prove to be positively can affect the outcome of the patient with diabetes. However, the new era of the cardiovascular outcome trials, starting with using either GLP-1 receptor agonist or SGLT2 inhibitors in patients with type 2 diabetes, demonstrated heterogeneous drugs. Regarding the GLP-1 receptor blocker, I think LEADER trial using liraglutide was the one that showed some benefit, and also the SUSTAIN-6 trial using the semaglutides, others showing neutral effects. So actually GLP-1 receptor agonist was the results was heterogeneous. However, starting the era of having a class of drug that not only affecting the glucose lowering, but also it may benefit some patients, prevent the cardiovascular disease outcome. However, the recent introduction of the SGLT2 inhibitors providing a novel insulin-independent and renal-based approach to controlling the blood glucose, and proved, as I will show you, to have cardiovascular outcome improvement and renal outcome improvement. And as Dr. Bendari illustrated very elegantly the mechanism of actions of these drugs, it acts on the proximal tubules, preventing by the glucose reabsorption by SGLT2 inhibitions, so increasing glucose in the urine, increase urinary glucose excretions, reducing the hemoglobin A1C, and leading to some diuretic effect. This is the mechanism of action. And actually, if we look at the summary of the cardiovascular outcome trial with SGLT2 inhibitors, we have a plethora of trials. We have the EMPA-REG outcome trials, the CANVAS trial using CANA, and the CANVAS-R trials. We have the CREDENCE trial, the DECLARE TIMI58, and the ertugliflozin C cardiovascular outcome trials. If you look at these trials, you have to look at the type of patient included in these trials. Some trials, like the EMPA-REG, are essentially secondary prevention trials, patients with established vascular complications. However, if you look at the DECLARE trial, for example, it is essential using dapagliflozin. It is essentially a primary prevention trials. Most of the patient high risk for cardiovascular event. So the type of the patients, the inclusion criteria is very important if you look at these drugs to drive some conclusion. Of course, we are building knowledge about the cardiovascular outcome data from SGLT2 inhibitors, and the first knowledge came from the EMPA-REG outcome and the CANVAS trials. These are essentially secondary prevention trials, because most of the patients here are more than 90% of the patient established cardiovascular disease. Here, more than around 70% of the patient established cardiovascular disease. So in these patients with established cardiovascular disease, this SGLT2 inhibitors showed improvement in the MACE 3-point and hospitalization for heart failure in these patients. So the expected cardiovascular benefit of the SGLT2 inhibitors may be due to the mild reduction of the blood pressure, the mild improvement in lipid profile, and reducing the congestive heart failure and the reduced hospitalization and mortality from congestive heart failure. And don't be take it easily this reduction in blood pressure, because mean reduction of 2 millimeter mercury blood pressure can decrease the risk of the cardiovascular event by from 7 to 10%. So this is one of the mechanisms maybe of benefit in the SGLT2 inhibitors. And most of the benefit are actually is not related to the hypoglycemic effect. It may be related to the weight reduction, the renal benefit reducing the albuminuria and the progressive decline in renal function, as was illustrated nicely by Dr. Bendari. The reduction of albuminuria is due to hemodynamic, but also due to metabolic and blood pressure lowering effect of the drug. So actually, if one can want to ask why SGLT2 inhibitors can lead to this cardiovascular and renoprotective effect, actually there is many factors and pathways that can lead to this benefit. Decreasing the blood pressure can decrease the arterial stiffness. Of course, decreasing the albuminuria and uric acids, decreasing the oxidative stress, the weight reduction, and decreasing the visceral adiposity, and maybe decrease sympathetic nervous stimulation activity. So actually, there is many postulated mechanism in these drugs. If we look at the SGLT2 cardiovascular outcome trials, I will concentrate on these three important trials: the EMPA-REG, the CANVAS, and the DECLARE trials. And actually, I want you to focus on the type of the patient in each of these drugs. EMPA-REG, mainly type 2 diabetes and cardiovascular disease, more than 90% established cardiovascular disease. The CANVAS, type 2 diabetes and around 70% established cardiovascular disease. The DECLARE is a primary prevention trials, multiple cardiovascular risk factor in 60% of patients and only 40% of patients with established cardiovascular disease. Evolution of dapagliflozin evidence actually 2018 كان البوزيتيف DECLARE data in a broad patient population. 2019 ground breaking results في heart failure with reduced ejection fraction patient with and without type 2 diabetes. 2020 the very astonishing and important data in chronic kidney disease in patient with this using the dapagliflozin. And actually, if we look at the pooled safety data from these 12 placebo-controlled trial, we'll notice that the few adverse effects lead to treatment discontinuation. Most commonly reported event leading to discontinuation with DAPA 10 milligram, some increase in blood creatinine, urinary tract infections, and maybe genital infection, as we'll see in a while. If we look at the DECLARE trial, which is the most important trial in the dapagliflozin cardiovascular outcome trial in type 2 diabetes, I want to concentrate on the inclusion criteria. We have the type of the patient, either multiple risk factors or established atherosclerotic cardiovascular, 60% multiple risk factor. And the importance of this type of the patient is that when you are dealing with a primary prevention case with mild renal impairment, you will expect that the number of deaths, even in the placebo group, is not so impressive. And that's why can explain why there is no reduction in all-cause mortality or cardiovascular mortality in the DECLARE trial, because you are dealing with a primary prevention patient that it is very difficult to see cardiovascular mortality benefit. And this is comparing the EMPA-REG atherosclerotic cardiovascular disease more than 90%, the CANVAS around 70%, and the DECLARE only 40%. So it is a primary, mainly primary prevention trial. Actually, the safety profile has been proven in these trials, we saw no evidence of higher risk of stroke, amputations, or fractures with DAPA than with placebo. Also, it was observed a lower rate of bladder cancer with DAPA than the placebo. However, the rate of diabetic ketoacidosis, you have to keep an eye on the diabetic ketoacidosis with the use of SGLT2 inhibitors, and also you have to keep an eye on the rate of genital infections, especially in female in this group. So the conclusion of DECLARE trial, that on the basis of results from previous trial before the DECLARE, current international guidelines for the management of diabetes have focused on the use of SGLT2 inhibitors in patients with atherosclerotic cardiovascular disease. However, after DECLARE, these new data suggest that in patients without established atherosclerotic cardiovascular disease, SGLT2 inhibitors can prevent serious clinical events. So after DECLARE, we can now, in the guidelines, use these drugs in case of primary prevention. What's new in this with dapagliflozin? The new is DAPA heart failure trial. DAPA heart failure trial with reduced ejection fraction, showing the effect of dapagliflozin in patients with heart failure with and without diabetes. So the question was, the benefit of SGLT2 inhibitors may be glucose independent, and you can even use these drugs in patients with heart failure without diabetes, as was illustrated in a previous presentations. And actually, in patients, whether with diabetes or without diabetes, you have a significant risk reduction in most of the endpoints. And this is nicely illustrated that those with diabetes or those without diabetes have the same beneficial effect with SGLT2 inhibitor dapagliflozin in this prevention cardiovascular outcome trial. What is new also is the DAPA in chronic kidney disease. And actually, again, in patients with chronic kidney disease, with or without diabetes, there is improvement and there is reduction of the event rate, and that was the conclusion of DAPA chronic kidney disease. In patients with chronic kidney disease with and without type 2 diabetes, DAPA compared to placebo reduce the risk of kidney failure, reduce the risk of death from cardiovascular cause or hospitalization, and prolonged survival. It was well tolerated also. And as you know, this lead to changes in the guidelines. And if we look at the guidelines among patients with type 2 diabetes who have established the atherosclerotic cardiovascular disease or indicators of high risk even without established cardiovascular disease, or those with established kidney disease or heart failure, here a sodium glucose co-transporter 2 inhibitors or glucagon-like peptide 1 receptor should be part of the therapy of these patients. Not only that, but also SGLT2 inhibitor may be more useful for patients at high risk of chronic kidney disease progression, example with albuminuria or a history of documented loss of eGFR or reduction of eGFR, because they appear to have large beneficial effect on the outcome. The SGLT2 inhibitors, CANA, EMPA, and the DAPA are approved by the FDA for the use with eGFR 45. However, some subgroup analysis showing that even up to 30 milliliter per minute eGFR may be used, however, cautiously, of course. So by the end of this, I want to thank again Biofactor company. And actually, when I asked them about their drugs, Diglifloz 5 and 10 milligram monotherapy, and Diglifloz plus, especially about the cost, and they told me that the cost is about maybe 200 or 230 pounds per month. So I would like to thank them for the support of this session. I leave the stage for the moderator if there is any comments or questions.
Dr. Ashraf, this is Nabil Farag. I would like to thank you very much for this excellent presentation. And very common questions about the dapagliflozin in a patient with heart failure with reduced ejection fraction. Now, we see that the guidelines are changing and the position of the ARNI are taking over the ACE inhibitors and ARBs. Now comes one of the first steps to add ARNI to beta blocker. What do you think the position will be of the dapagliflozin in a patient with heart failure with reduced ejection fraction, whether they have diabetes or not?
Do you think that it will be at the same position of ARNI? And as you show us, there are ongoing trials in the future that will combine both the dapagliflozin and the ARNI in the treatment of heart failure with, and so we will have this combination in the future. What do you think, Dr. Ashraf?
Well, actually, Dr. Nabil, this is very important questions because actually the positive data of the SGLT2 inhibitors in patients with heart failure, whether they have diabetes or not, are very impressive. Dr. Noumani showed us a very nice slides about the 4 gold pillars of treatment of heart failure now in view of the American standard or even European standard, and they include ARNI, SGLT2 inhibitors, beta blocker, and MRA, mineralocorticoid antagonist. These are now become 4 pillars in the treatment, and then according to the other situation, the other parameter, you can add other drugs in the treatment for failure. It seems that they are now getting more and more privileges in being in the first 4 classes of drugs that should be put in a patient with heart failure with and without diabetes.
So we can start with the 4 together as the first step in the management of heart failure.
It seems that
Yes.
this is the ideal treatment of heart failure patients.
Yes.
Thank you دكتور أشرف.
نبيل اسمح لي ممكن بس لحظة واحدة دكتور سامح، لحظة واحدة. دكتور نبيل فرج، انا محمد النعماني، بس جاست شورت كومنت بعد اذن حضرتك دكتور اشرف. انا عايز بس اضيف حاجه بالاضافه للفور بيلرز اللي دكتور اشرف رضا قال عليهم. هو الامبرو ريديوسد ترايل كل الفيفورابل افكت في الامباجليفلوزين كان اون باك جراوند اوف ذا ستاندرد ميديكال كير انكلودينج ارني. يعني كان في سبيسيفيك سيلكشن كرايتيريا. هم عملوا حاجه ظريفه جدا، الناس اللي كان عندها ماركلي ريديوسد ايجكشن فراكشن ما كانش مشترط ان البي ان بي فيهم يبقى عالي. الناس اللي كان عندهم هاير ايجكشن فراكشن كان مشترط ان البي ان بي لازم يبقى فيهم عالي. الفيفورابل افكت ظهر في حوالي 30% من البيشنتس، دول كلهم كانوا على الستاندرد ميديكال كير انكلودينج ارني. فهو الراشونال دلوقتي ان انا ستارت وذ ذا 4 بيلرز، يمكن زي ما الدكتور اشرف رضا قال.
هو اعتقد بعد اذنكم يعني هو الفوكس ابديت بتاع الامريكان كولج اوف كارديولوجي اللي هي اتعملت على الهارت فيلير جايد لاين تريتمنت، حطت الاس جي ال 2 من غير اي كونترا انديكيشنز. اي بيشنت عنده ايجكشن فراكشن اقل من 40 والجي اف ار بتاعه اكتر من 30 ياخد الدواء.
تمام.
فدلوقتي ما اعتقدش ان هو بقى يعني البوزيشن بتاعهم بقى from the start زي ما الدكتور نبيل قال زي ما حضرتك قلت يا دكتور اشرف، ان انت بتبتديهم as early as possible for their يعني cardiovascular protective benefit و reduction of heart failure hospitalization.
ليه سؤال دكتور سمير معاك، اللي هو ابتدي ب5 ولا 10 مللي جرام لو عيان مش هارت فيلير ومش دايابيتي؟ دكتور اشرف السؤال بتاعي اللي كنت سالته.
هو طبعا يعني احنا مش دايابيتولوجيست يعني وانا مش فاكر الديزاين بتاع الترايل كان كله بياخد 5 ولا 10 ولا كانوا بيزودوا الجرعه. هل في حد عنده فكره الترايل كانوا بيدوا؟
كله كان
10. هو 10 يا دكتور اشرف، 10 مللي جرام و5 للبيشنتس اللي عندهم هيباتيك امبيرمنت. يعني
بس هي يمكن الامباريج اوت كام كان فيها 3 ارمز بلاسيبو 10 مللي جرام 25 مللي جرام.
تمام.
هاني راجي عايز يقول حاجه.
بس عايز اقول كلمه سريعه خالص على الميكانيزم which was not mentioned. ضمن الحاجات هو ان الهيماتوكريت بتاع العيانين دول بيعلى والانيميا بتبقى عندهم اقل، والانيميا is very deleterious في الهارت فيلير.
تمام.
في 3 proposed mechanisms في القصه دي. واحد منهم هو السمبل هيمو كونسنتريشن اللي مفترض ان ده بيعمله، بس it's not as simple as that. في حاجتين. في اول حاجه ان وظيفه الكلى بتتحسن، الاريثروبويتيك فانكشن بتاعه الكدني is improved وده بيحسن الهيموجلوبين والهيماتوكريت وبيقلل انيميا. وفي حاجه تاني ان في سبستنس بروتين توكسيك بروتين انفلاماتوري اسمه هيبسيدين. الجليفلوزين الداباجليفلوزين بيشتغل انتي هيبسيدين، وده بيسمح بمور اريثروبويسيس وباتر هيماتوكريت، وده might be one of the most important mechanisms في الايفنت ريدكشن وكده، انه العيانين دول عندهم انيميا اقل وباتر يوسج للهيموجلوبين والاكسجين طبعا. شكرا.
دكتور سيد عايز يقول حاجه؟
اتفضل. دكتور اشرف، يعني very elegant presentation as usual. الحقيقه we are very lucky to live in the era of counteracting one of the major problems like heart failure. Now the CRT doing the resynchronization and sometimes reducing the ejection fraction. The ARNI is doing the job, and also the SGLT2 inhibitors. We are very lucky. As a man, we have no options for treating heart failure. لكن so far after all this evidence, I'd like to tackle a practical point. What about the use and the titration up and the titration down of the diuretics when we are using the SGLT2 inhibitors? Do we need to reduce the dose of diuretics to stop it, or we keep the patient on the same dose of diuretic he is kept on? This is, I think, a very important practical question. I don't know if anyone has a comment or answer for this.
Yes, I think this is an important observation, Dr. Said, because hypovolemia is one of the side effects of these agents. If you are not keeping an eye on the other medications. So I think one should put in mind that one of these effects of these drugs is diuresis. So it's important to before starting to look at the blood pressure. It's important to look at the EGFR and renal function, to look at the other drugs, and especially if the patient is on diuretics. And I think one should reduce the diuretic dose before starting such drug, especially if the blood pressure is low and the EGFR is high and the patient is not very congested. So why give him a lot of diuretic? Any other commentary?
Thank you all. A very good, important point, Professor Said. This is not published still, but the sub-analysis of the DAPA heart failure study showed those taking more than 40 milligrams of furosemide as a chronic therapy. This is not acute heart failure, okay? Chronic therapy or equivalent to 40 milligrams of furosemide مع dapagliflozin, the possibility of dehydration is significantly increased a little bit. But this is still not published, but the data is there, and it was presented in Heart Failure Association meeting just last June.
دكتور اشرف، بس انا احب ازود حاجه بعد اذن دكتور نبيل. هو الامريكان كولج اوف كارديولوجي اللي هو احنا قلنا 2120 اكسبيرت باسواي ديسيجن، اللي هو يمكن اخر حاجه الشهر اللي فات، هو قال ان انا هبتدي الفور دراجز لو البيشنت كونجستد او ان ويت ستيتس، بريفيرد ان انا ابتدي بالارني او اي انالوج ليه مع الفور بيلرز الباقيين، وممكن احط الدايوريتك لو البيشنت از ان كونجستيف ستيتس او ويت ستيتس. بعد كده افتر ستابيلايزيشن بشرط ان الهيموداينامكس من الاول تبقى اوكي، ستيبل هيموداينامكس. After achievement of favorable stable condition, I can downgrade the dose of diuretics. انما ما كانش في كلام خالص في الكونجستيف ستيتس سبيشالي في الهيفريف ان انا اوصل لمرحله ان انا استغنى تماما عن الدايوريتكس. But يعني we are still awaiting for more favorable evidence.
I think we can shift to other
areas. بالظبط كده دكتور عايز حاجه؟ يعني I think we have to move لل
Okay, go ahead.
And احنا it's time late and we have to move to the second speaker and okay. It's my pleasure to introduce my dear friend Dr. Ahmed Shawqi. Dr. Ahmed Shawqi is one of the excellent speakers. I used to enjoy your presentations, Ahmed, على طول طبعا وعارف. And he will present today a very important topic about hypertension. Are beta blockers out? And this is one of the controversial topic we used to discuss every day. Please, Dr. Ahmed.
Thank you so much, Professor Nabil, for your lovely words. You're a big brother. You're a mentor to me and to all other cardiologists all over the country and the world. Thank you so much. This is a really important question. What to give in diabetics? I know you might think the answer is quite simple. Just ACE, ARBs, and that's it. let's take a look. First of all, I will, I have a disclosure. I'm presenting on behalf of Biofactor Markel. And we know that diabetes, like Professor Ashraf said, is, over 400 million people around the world. But the problem is, in our countries, in the Middle East, it is increasing so much rapidly. Egypt expected by 2045 to jump from the 9th position to the 7th position in the most number of diabetics. Look at the countries before us. They're all much more populated than us. This is a really big problem that we should take into consideration. Not only that, diabetes by itself increases the risk of cardiovascular disease as compared to the general population, and the risk factors start much earlier than the onset of the macro or microvascular disease. So it's a patient journey that starts with risk factors. Control them, control the diabetes, then you might really avoid a lot of problems. That's to say that patients with diabetes that have cardiovascular disease probably have a lesser life expectancy by around 10 to 12 years. So actually improving the outcomes in diabetes and cardiovascular disease will improve morbidity and mortality. And as we saw in 2018, 2019, and before that, diabetics, the ones we see as cardiologists, are either probably very high risk or high risk. Very few of them are in the moderate or low risk. So reduction of cardiovascular events is important. And if you look at what the data says from all diabetic registries and guidelines, on the top left, number one, hypertension. Blood pressure control, because hypertension is the commonest risk factor in the world, is very important to do. I know this is, an older slide of 2018 before the European guidelines, but targeting lower blood pressure is important. So as we saw in the first presentation, targeting LDL and diabetes control. And collectively, blood pressure control, and this is data from more than 100,000 patients, reduces the mortality risk, reduces the stroke, reduces the heart failure, reduces coronary artery disease. Blood pressure control is good, not only in diabetics, but also in non-diabetics, but it's important. And we are sad to say, in our countries, especially in Egypt, we're not doing well, whether controlling blood pressure, controlling ischemic heart disease, or the mortality in cerebrovascular disease is quite high. Quick recap. November 2017, American College of Cardiology, American Heart Association, and another 11 entities published these guidelines saying that anybody above 130/80 is stage 1 hypertension. And everybody should target a goal below 130/80. I know this shook the world, November 2017, but came the guidelines of the European Society of Cardiology, August 2018, and they said rather the same. They put the categories and controlling the blood pressure according to the risk. That is to say, if you're grade 1 hypertension or even high normal blood pressure and having high risk, you have to give therapy there. But if you're grade 2 or grade 3 hypertension and your risk is regardless of the controlling of the blood pressure, you should immediately treat all these patients. And again, targeting below 130/80, except in chronic kidney disease and in the elderly, 140/80. And 80 here is constant throughout the guidelines. Just last year, actually, and we know the Canadian guidelines are updated nearly every single year, and they put an extra bit on this, if you look at it. Unless the blood pressure on the first office visit is 180/110, then you have to look at the next point, which is the presence of diabetes. And here comes diabetes. Then we control, because diabetes by itself, as the Canadian guidelines said, is incredibly important risk factor. And they said, this was a little bit different, I know, from the American and the European guidelines. You can use any medication. Beta blockers included from the start, unless, of course, the patient is old. And we know in elderly people, the risk of stroke is higher than the risk of myocardial infarction. And that is why beta blockers are not preferred in the elderly. But they put thresholds and targets. And I just want to show you in the second row, diabetes by itself is a risk factor and is a target below 130/80. So did the ADA that was just published last month. And they said, again, 130/80, this is consistent between the guidelines. The numbers are the same, but those at low risk, we can go to 140/90 as a target. And those with pregnancy, I don't know how they get the numbers here, but 110 to 135/85, I have the references, and there you can see it. So diabetes is important. Diabetes is a risk factor, and it should be treated regardless. So I'm going to skip a little bit of the slides and go to an important question. So is it just the numbers of the blood pressure, or does the heart rate really take in consideration? And this diagram just sums a little bit it up. We know we have many interactive systems that control the blood pressure: the sympathetic nervous system, the renin-angiotensin-aldosterone system, and the sodium content, which we really are good eaters. And we know the sympathetic nervous system is quite prevalent in the young, and this is Egypt. If you look at the pyramid, we're young. Very few people are in the elderly part of the pyramid. And as heart rate goes up, on the left, in normal individuals, it increases mortality. On the right, in patients with hypertension, it increases mortality. So heart rate is a risk marker, a risk factor, whatever you call it, it's something which is deleterious. And we've seen the advent of beta blockers since the 50s. They have changed a lot. We have two receptors, the beta 1 and beta 2, and they have been evolving. We think of beta blockers with the propranolol, that was the first one, then the selective atenolol and the metoprolol tartrate, which was the first ones. And really, beta blockers had a lot of bad reputation because of these two medications, the atenolol and the metoprolol tartrate. But heart rate, going back to heart rate, it includes a lot of things. This just sums a lot what heart rate and sympathetic activation can cause in the patient's body, so it's not something simple. Heart rate can increase atherosclerosis through increasing deposition in the lumen, reducing arterial compliance and increasing plaque ruptures. And here in this study, it showed that there is a triple increase in plaque rupture if the heart rate is above 80. And in the value study, a study for valsartan and hypertension, those with a low heart rate fared the best. So again, this was not a beta blocker trial. Those with a lower heart rate did better in the follow-up of the primary event rate. And again, those with the mortality can increase in the heart rate in those with hypertension and left ventricular hypertrophy. And all increase 10 beats in heart rate can increase cardiovascular events by 25%, as seen by these curves. So heart rate actually is not simple. But the question comes, the beta blockers invented by Professor Black, are they all the same? It was the first non-selective beta blocker, propranolol, and then the second generation of beta 1 selective like atenolol, bisoprolol, metoprolol, tartrate, and then improved to succinate. But the third generation, which is the more vasodilatory, which is carvedilol, which I should remind you is non-selective. Carvedilol is a non-selective beta blocker, alpha blocking effect, good for vasodilatation, but also nebivolol. Nebivolol is a selective, beta 1 selective beta blocker and increases nitric oxide. And this nitric oxide really improves a lot of the vasodilatory effects of nebivolol, reducing the counteractive effects. And that is why it differs through different mechanisms than other beta blockers. It is beta 1 selective, does not have any alpha blockade. It is lipophilic without an increase in intrinsic sympathomimetic activity. But this nitric oxide may be the magic part of nebivolol. And that is why, when compared to other selective beta blockers, it is more selective, doesn't have an effect on the chronic obstructive airway disease, no effect. In fact, the beta 3 agonist effect may be effective in improving glucose metabolism or just being neutral, and again, the same in lipid metabolism. And this increasing in nitric oxide improves endothelial function, and we'll see data to show that with a decrease in platelet activation and thus improvement in erectile dysfunction and no major fatigue that is caused by the other beta blockers. And this is data First of all, if you want a medication, you want a medication that reduces blood pressure. And here, compared to bisoprolol, one of the most commonest used beta blockers all over the world, and in our country, I think it's number one, it is effective with a less adverse event rate. Not only that, it is better in arterial distensibility as compared to atenolol. This is significant. The endothelial dysfunction or imbalance through nitric oxide, through endothelial function, is much, much, much better than atenolol. And in data, I'm not trying you to take a look at this really busy slide, but this is data from Benefit Korea. And in those patients above 60, it was either beneficial or neutral on the lipid and glucose profiles. So it's very safe. And when we talk about beta blockers, we talk about side effects, I know. Actually, in COPD, there is an important cause of death. The number one cause of death in COPD is cardiovascular events, to be sure. So we shouldn't deprive those from beta blockers unless, of course, in an acute severe asthma or definitely a lot of wheezes. And in type, in beta selective, beta 1 selective blockers are actually neutral if you look at this objective evidence of respiratory function. Erectile dysfunction, I know it's multifactorial. It has a lot of intermingling factors, but definitely selective beta blockers are rather neutral. But more and more, nebivolol, through its vasodilatory effect, has shown through multiple studies that it improves even erectile dysfunction. Those that had erectile dysfunction on some selective beta blockers had 70% of them had an improvement in the erectile dysfunction score when shifted to nebivolol. The central aortic pressure, an important part to say that all blood pressure medications, yes, they lower the blood pressure, but central aortic pressure is more important in reducing strokes. And this was the problem with atenolol in the ASCOT study. This study is nebivolol, atenolol, showing similar systolic and diastolic reduction of blood pressure, but the central aortic blood pressure was markedly reduced by nebivolol than atenolol. That is why the guidelines, when they put the beta blockers, if you read the text, this is more important. If you look at what it said here in the ESC 2018, it says nebivolol and others like celiprolol, labetalol have more favorable effects on the central blood pressure. This is not my quotation. Aortic stiffness, endothelial function, with no adverse event on the new onset diabetes, a problem with atenolol, the older metoprolol, a favorable side effect than the classic beta blockers, especially on sexual function. So they're not the same, definitely, and even the guidelines, the updated guidelines say that. And they state every hypertensive patient should have his heart rate or her heart rate measured. And those with a heart rate above 80 are considered at risk. Here you go again. You look at the heart rate for every patient with hypertension, not only to control the heart rate, but also to look for arrhythmias. And you can use 2018 guidelines, any medication according to the compelling indications in the patient. And the 2017 American guidelines also state that the new vasodilatory beta blockers like nebivolol are neutral or favorable on the metabolic profiles as compared to the traditional beta blockers. Thus, again, nebivolol is named here by name. So beta blockers are not out. Diabetics or non-diabetics, they have a lot of compelling indications. Us as cardiologists, we've never reduced our beta blocker prescription rate. In strokes, in myocardial infarction, angina pectoris, heart failure, definitely, aortic aneurysm, atrial fibrillation, and also in pregnancy and others. We can use them in all patients. So to take home, hypertension is a major risk factor in diabetes. I know the day today is about diabetes, but the most prevalent risk factor is hypertension, even in diabetics. And most of the benefits of antihypertensive arise really from the mere reduction. We've seen the nice slide by Professor Ashraf showing a 2 millimeter reduction in systolic blood pressure reduces mortality from stroke, and this is important. The sympathetic nervous system and heart rate do have an important role in hypertension. Our patients are young in our country, and they are more prevalent to have an increase in sympathetic tone. Thus, beta blockers, whether in diabetics or non-diabetics are beneficial. But when choosing beta blockers, not all beta blockers are the same. Not all beta blockers increase the lipid profile or the blood sugar. Not all beta blockers produce vasodilator effects, reduction of endothelial dysfunction, reduction of erectile dysfunction. I think nebivolol here is a winner. And thank you.
Thank you very much, Dr. Ahmed, for this excellent presentation, as usual.
Thank you.
And it's a very old, like to say that ظلمت بسبب الاتينولول. الاتينولول is a short acting يستعمل في الكلينيكال ترايلز as once daily treatment and associated with increased risk of stroke في العيانين hypertensive patients. That's why beta blocker was declined to be in third or fourth step in the treatment of hypertension and to be used in a compelling indications. Ahmed, يعني should يعني and still there is debate about beta blocker and the management of hypertension with the new drugs, especially those of beta and nitrous oxide effect, not the other vasodilator beta blockers, which has a non-selectivity on the beta receptors. Between the three generations of beta blockers, and I think this will make some changes the future guideline. Dr. Hani, say something.
لو ممكن بس تسمحوا لي اقدم سلايد واحد لو سمحتوا. هو just دي نقطة حبيت اوضحها، ان احنا زي ما ابتدينا في at the beginning of our practice where when I was a fellow, if I had prescribed beta blocker to a patient with heart failure, I would have probably lost my job. It was malpractice. And now beta blockers are class 1A in treatment of heart failure. This is a paper which is changing practice, which came out in December 2020, was published in the European Heart Journal, in which the association of beta blocker use was studied in association with survival and pulmonary function in COPD patients. And the conclusion was, which you can see on your right hand, is that the use of beta blockers in patients with chronic obstructive COPD is not only safe, but it actually reduces their all-cause and their in-hospital mortality. And that cardioselective beta blockers reduce chronic pulmonary disease exacerbations. In addition, they do not affect the action of bronchodilators. Importantly, the beta blockers, as was said elegantly by Professor Ahmed Shawqi now, reduce the heart rate acceleration, which is in these cases is caused by bronchodilators and other reasons. And it concluded that beta blockers should be prescribed freely when indicated in patients with COPD and heart disease. And like we are making a lot of effort with diabetologists to get them on board to prescribe cardiobeneficial diabetes drugs to their patients, the same problem we have to face with chest physicians. I mean, I have sent this paper to several chest physicians, and several replied with amazement, but I mean, one of them said it was kalam farigh. Of course, it's not kalam farigh. This is science, and I think, I hope we'll all be alive and see this, but I think beta blockers are gonna be removed from the list of contraindicated drugs in COPD very soon. Thank you.
الحقيقه دي ملحوظه يا دكتور هاني فعلا مهمه جدا، وانا بنشوف ساعات عيانين يكونوا عندهم كرونيك سباستيك برونكايتس وماشيين على بيتا بلوكر، والواحد يجوا لنا وتلاقيهم كويسين، يعني مش ساعات الواحد يبص على البيتا بلوكر كده ويقول له يعني انت مش في اعراض زياده بتاع، وفي ناس تقللها وفي ناس ممكن توقفها.
ممنوع في البرونكيال ازمه يا بروفيسور، ممنوع في البرونكيال ازمه، بس مش ممنوع في السي او بي دي.
لو في evidence of bronchospasm يا دكتور اشرف هو ده انما السي او بي دي نفسه as long as ان مفيش bronchospasm ده مش كونترا انديكيتد ان احنا نستعمل بيتا بلوكر.
واحيانا كمان بعد اذنك دكتور نبيل مع البرونكودايليتورز the patient can tolerate the beta blocker especially لو هي كمان كارديو سيلكتيف.
هو
Yes.
كمان يعني النيبيفيلول يعني لانه هايلي سيلكتيف، فما بيشتغلش على التيشوز بتاعت اللنج، يعني ممكن يتاخد سيفلي حتى ايفن في الناس اللي عندهم برونكيال ازمه بس ما عندهمش طبعا برونكوسبازم، لكن
تمام.
غير بقيه السيلكتيف بيتا بلوكرز يعني.
انا اجري تماما للكلام ده. انا يعني this molecule is a good يعني كمان هيحسن سمعه البيتا بلوكر في الناس اللي عندهم يعني اذا كان عندهم some chest problems والناس dysfunction او erectile dysfunction. I think this will be يعني a good drug to be used in such patients.
طيب إذا كانش في any other questions I think يعني I have to thank all these distinguished faculty. والحقيقة faculty حاجة يعني الواحد سعيد إن احنا بنلتقي مع بعض. صحيح الساعة 11:30 بالليل إنما يعني إيه سهرة جميلة فيعني سهرناكم معانا واي هوب ان انتوا استمتعتوا معايا بالبرزنتيشن
شرف لينا يا دكتور اشرف.
شفناها. وطبعا احب اشكر بايو فاكتور للسبورت للايافا CME اكتيفيتي. بشكركم يا جماعه جميعا ودايما نشوفكم كده على خير. اتمنى لكم دايما صحه جيده.
ان شاء الله باذن الله نتقابل قريبا.
ممكن اقول نقطه اخيره يا دكتور اشرف؟
نعم
اقول نقطه اخيره.
قول.
انا كنت في ميتنج في الجامعه الامريكيه من اسبوعين بخصوص الجينيركس والادويه الرخيصه والجينيركس المصري انكلودنج الجينيركس بتاعت ادويه لسه رخصتها العالميه ما انتهتش. وكان في هناك سوري يعني مش هقدر اقول هو مين بس يعني هو الميتنج انما كان في هناك خبير مصر الاول بتاع وزاره الصحه والصيدله بشأن جوده الادويه، وهو اكد لي بنسبه 500% ان مفيش ولا دواء جينيريك نازل في مصر بتنتجه شركه مصريه في اي شك في مصدر المولكيول بتاعه او في كفاءتها. واكد لي تاني ان هما بيفحصوا روتين مش كل باتش بس very frequently البايو ايكوفالنس. يعني انا ما بقول له انا قلقان من الادويه النيو اورال انتي كواجلانتس والنيو انتي دايابيتكس دي ان انا ادي جينيريك لعيان، قال لي انسى الموضوع ده، انت اكشلي لو ما كتبتش جينيريك يبقى عندك مشكله. حبيت بس اشارك المعلومه دي معاك.
وفعلا الوزاره الكام سنه اللي فاتوا اكتيفيتد جدا التشيكنج على البايو افيلابيليتي وبقى في عندهم فعلا باث ويز للموضوع دوت ورقابه عليه تخلي الواحد عنده ثقه ويبقى مطمئن غير زمان ان ما كناش بنبقى كنا قلقانين كده. فعلا اعتقد يعني مع التطور الجديد ده فبكلمه دكتور هاني راجي ديت نقول تصبحوا على خير ونشوفكم دايما بخير يا جماعه. باي باي. See you.